Welcome to The Explainer. Today we're jumping into two conditions a pediatrician might spot the moment a baby is born: hypospadias and epispadias. Now they both involve the urethra, but you're about to see they are truly worlds apart in just about every way.
So for most newborn boys, the urethra opens right at the very tip of the glans. But what if it doesn't? What if that opening is somewhere else entirely? Well, that's where we find the two conditions we're exploring today.
The main difference between them, and it's a really simple one, is all about location. With hypospadias, the opening, what we call the meatus, is on the ventral surface. That's the underside. For epispadias, which is much rarer, that opening is on the dorsal, or top surface.
Okay, so let's really get into it. And we're going to start with hypospadias, because it's by far the more common of the two.
So you might be wondering, just how common is this? Well, hypospadias is actually the second most common genital anomaly in boys. It affects about 1 in every 250 male births. So yeah, it's something pediatricians and parents encounter pretty frequently.
So what's actually going on here? How does this happen? It all comes down to how the urethra forms during development. On the underside of the penis, there's a groove that fuses together, moving from the base out toward the tip. Honestly, the best way to picture it is like a zipper closing up.
And this shows you exactly what happens with hypospadias. That zipper simply stops before it gets all the way to the end. And the spot where it stops, well, that becomes the new location of the urethral opening, somewhere on the bottom instead of at the tip.
But you know, hypospadias is more than just where the opening is. It's often a trio of things you see together. Besides the misplaced opening, there's often a downward curve to the penis, which is called chordee. And because the urethra didn't fully form on the bottom, the foreskin usually doesn't either, which gives you this dorsal hood. Plenty of foreskin on top, but almost none on the bottom.
We actually classify how severe it is based on where that opening ends up. The mildest form, and the most common, is distal. That's about half of all cases, where the opening is pretty close to the head of the penis. Midshaft is next at around 30%, and the most severe is called proximal, where the opening can be all the way back by the scrotum or even further.
Okay, so that's hypospadias. Now let's switch gears completely and talk about epispadias, which is, well, it's a whole different story. If hypospadias is common, epispadias is the exact opposite.
Just look at these numbers. It's pretty incredible. Isolated epispadias, and that means it's not part of a bigger issue, occurs in just 1 in 117,000 male births. That is incredibly rare.
And the reason it happens is totally different from hypospadias. This isn't about that zipper failing to close. Nope, this is a much more fundamental issue, one that starts with an error in how the lower abdominal wall itself developed.
In fact, isolated epispadias is really just the mildest version of a whole spectrum of conditions. It's called the bladder exstrophy epispadias complex, or BEEC for short. In the more severe forms of BEEC, the bladder can actually be exposed on the outside of the body.
So, okay, a pediatrician spots this at birth. What happens next? What's the path forward for the family? Well, it all kicks off with one really crucial piece of advice.
And this is arguably the single most important initial message for parents. For any baby with hypospadias or epispadias where the foreskin looks abnormal, routine newborn circumcision absolutely must not be performed. And there's a huge reason for this.
And here it is. That dorsal hooded foreskin. It's not just extra skin. To the pediatric urologist who's going to do the repair, it's like gold. It is precious building material that they will use to reconstruct the urethra. Trying to do a circumcision could remove this vital tissue and even damage what's underneath.
So the journey for the family is pretty clear-cut. After the diagnosis at birth, there's a prompt referral to a pediatric urology specialist, usually within the first few weeks or months. And the surgery itself? That's typically scheduled for some time when the baby is between 6 and 12 months old. Now, for the more severe forms, those proximal cases, especially if they show up with other things like undescended testes, well, doctors are going to do a more thorough check. They want to make sure there aren't any other related genitourinary problems hiding in there.
Which leads us to, really, the big question, right? After the surgery is done in that first year of life,
what does life actually look like for these kids as they grow up and become adults?
And the news here is overwhelmingly positive. The goals of surgery are to straighten the penis and bring that opening to the tip, allowing for normal peeing and normal sexual function later on. And for the vast majority of patients, those goals are met. Most men report being really satisfied with both how things look and how everything works.
Now, while surgery is highly successful, complications can happen, sometimes months or even years down the road. This can include things like a small leak or hole forming, a narrowing of the new opening, or other urinary symptoms. And that's exactly why long-term follow-up with a urologist is just so important.
And this really highlights a powerful truth, doesn't it? The goal here isn't just about one successful operation when they're a baby. It's about setting them up for a whole lifetime of normal function, health, and confidence. It's a profound reminder that the care given in that first year of life can lay the foundation for decades of well-being.